Deep inside the human body lies an environment engineered for protection, the female pelvic cavity during the second trimester. Obstetric guidelines are universally clear on one point. In a normal, uncomplicated pregnancy, physical intimacy is entirely safe. Yet this presents a biological paradox. The uterus houses a developing, highly sensitive organism, which naturally makes any physical interaction in the region feel intuitively dangerous. That instinct, however, stems from a misunderstanding of human anatomy. We often equate physical proximity with physical danger, assuming closeness implies vulnerability. Fetal safety is built upon a highly engineered, multi-layered biomechanical defense system. This visual breaks down that defense into three distinct pillars: the anatomical barrier, the hydrostatic shield, and muscular integrity. Hearing vague reassurances like penetration doesn't reach the fetus is rarely enough to alleviate clinical anxiety. To understand the mechanics, we have to look at the precise millimeter distances separating these environments. We also have to separate normal physiological responses from actual pathological dangers, because harmless biological reactions are frequently mistaken for impending harm. Once we map out how these normal biomechanics function, we can pinpoint the exact medical conditions where physical intimacy actually does become a threat. To comprehend obstetric safety, we must first deconstruct the functional anatomy of the pregnant pelvis. This 3D cross-section illustrates the lower pelvic anatomy, showing a hard boundary separating the vaginal canal from the amniotic sac. That boundary is maintained by the cervix. It operates as a thick, elongated muscular bottleneck, structurally locking the lower portion of the uterus completely closed. But the structural lock is only the first line of defense. It is reinforced by a secondary biochemical mechanism known as the cervical mucus plug. Within this canal, the mucus plug populates the space to create a dual-action barrier. It is an impenetrable mechanical seal against physical intrusion and a highly effective antimicrobial shield blocking external pathogens. Because of this double locking mechanism, any external physical penetration mathematically cannot bridge the gap into the fetal environment. The fetus remains entirely isolated. This precise structural separation neutralizes any risk of localized physical trauma or bacterial transfer during intimacy. Moving beyond the cervical gateway, we enter the broader environment of the uterus itself, the amniotic sac. This fluid dynamics model identifies the amniotic sac as an advanced hydrostatic suspension system that fully encapsulates the fetus. To understand its protective power, we rely on a core principle of fluid dynamics: liquid is incompressible. When kinetic energy, like physical movement or external pressure on the maternal pelvis, strikes an incompressible fluid, that force cannot travel in a straight line. Instead, the energy is instantly and evenly distributed outward, entirely bypassing the center where the fetus rests. This continuous radial dispersion acts as a 360-degree shock absorber, preventing any direct transfer of blunt force. As a result, intimate physical movement is structurally incapable of disturbing the developing organism. The hydrostatic fluid dissipates the kinetic energy before it ever reaches the fetus. Yet, even with these physical barriers in place, there is a common physiological side effect of prenatal intimacy: postcoital uterine cramping. This heat map model displays the uterine wall reacting to an endocrine trigger. During intimacy, the brain releases oxytocin, which triggers a localized, mild contraction in the uterine muscle that slowly fades back to a resting state. Clinically, these are classified as Braxton Hicks contractions. They are transient, entirely irregular, and self-resolving. Contrast that mild response with the pathology of true preterm labor, shown here as a cascading, highly rhythmic pattern that forcefully pushes downward to structurally dilate the cervix. In a healthy uterus, the brief surge of oxytocin from intimacy lacks the sustained biological momentum required to initiate the aggressive positive feedback loop of true labor. Therefore, post-intimacy cramping is a signature of a healthy, functioning endocrine and muscular response. It is not an indicator of impending structural failure or fetal distress. Obstetricians only restrict physical intimacy when these established biomechanical shielding systems are explicitly compromised. This diagram compares a normal pregnancy with our first major pathology, placenta previa. On the left, the placenta attaches at the top. On the right, the highly vascular placenta has attached at the bottom, directly covering the cervical opening. This creates a clear mechanical point of failure. Because the tissue is exposed right at the cervical junction, localized pressure or impact threatens to agitate and rupture those blood vessels, leading to severe hemorrhage. The second major pathology is cervical insufficiency, sometimes referred to as cervical weakness. When the cervix prematurely dilates or shortens, the structural widening completely negates the primary muscular barrier and dislodges the mucus plug. This specific structural failure strips away the antimicrobial seal, drastically elevating the risk of ascending bacterial infection and leaving the uterus undefended against triggers for preterm labor. Medical restrictions on intimacy, therefore, are never arbitrary. They are prescribed exclusively when precise anatomical or vascular vulnerabilities are present. The cervical seal, hydrostatic fluid, and muscular walls work together, forming a cohesive biological shielding system that protects the fetus. The safety of physical intimacy is a direct testament to the resilient, mechanical reality of human reproductive anatomy. Normal interaction simply cannot bypass the closed cervix, breach the antimicrobial seal, or compress the kinetic dispersing fluid surrounding the fetus. And brief muscular responses are just evidence of a dynamic, healthy system responding to standard endocrine signals, entirely detached from the mechanics of pathological labor. The pregnant body functions as a highly fortified biomechanical environment. Ultimately, this system is explicitly engineered for baseline safety, assuming the absence of underlying structural pathologies. This underscores the vital importance of routine prenatal screening to identify invisible anomalies, like placenta previa, before they ever become critical points of failure. Patients must always defer to individualized obstetric guidance tailored to their specific anatomical realities. By understanding the exact biomechanical reasons why these medical guidelines actual health with your healthcare provider to ensure your system is operating exactly as designed.